Is he gonna do it now?
What's that?
Replace your machine?
I don't know, but the other day when we were messing with this stuff, we were like, he's like, I'm not even going to try to fix this. So I'm assuming I don't
Yeah,
at the moment.
you need a new computer.
Well, there's one laying over there. It's just hooking it up. And I actually asked him the other day, I said, what are the chances of hooking mine up? And he allowed us how that could be done.
Do you want me to shut this?
Yes, but I got to get my shit organized. So before you do, I got to make sure this needs to be shut off. Six. I got to make sure I've got this share right. Here we go. Share. Share. Okay. Doesn't work. Background looks bad there. So let's do this guy here. And that looks a little better. Should have something to set it on. All right, let's admit these people into our thing.
Okay, you good?
I'm good.
Okay.
Oh, okay.
Do you want more hot water or are you set?
You could bring me a little bit when I turned it on.
Okay.
Can you hear me?
Yep.
Can you hear me?
Yep.
So let's go ahead then and get started. Yes, Dana.
Oh, no, I was just saying, yes, I can hear you.
Oh, okay. Very good. Thank you. Okay, so I am Eileen Doherty, and I am the director of the Colorado Gerontological Society. And our goal today is to talk a little bit about advanced care planning and looking specifically at DNR's CPR feeding tubes and ventilators and what that means for consumers. So the advantages of having advanced directives basically are to ensure that your wishes for whatever medical care it is that you want is honored, especially if you're not able to advocate for yourself, or if you're feeling like you're a little bit unsure about making decisions and you want somebody that you can check in with and or that you can call on to help. Sometimes people are able to speak for themselves when they initiate their advanced directives, but they don't necessarily trust their judgment or they want confirmation of it. An advance directive allows you to designate who that person is, who your agent is, who's going to be making those decisions, and how you want them handled. They also have the ability then to, in advance directives, you can talk about the types of care, both emergency care as well as life-sustaining treatment that you want. And at the end of the day, it really does help your loved ones to make sure that they understand how you feel and what it is that you want. Probably the most important thing is that it is a legal document. The disadvantages of advanced directives is that you may not understand what it is that you are signing. I see this very often when I am with people who get admitted to the hospital, and Medicare has this rule that says, do you have a medical power of attorney? And if you answer no, they hand you a form and tell you that you have to fill it out in the moment as part of your admission. And unfortunately, from my perspective, most of the time, then the people who are in that kind of emergency situation do not have time to have discussions or to make any type of real decision making. But the hospitals are kind of at a disadvantage because they are required to get you to fill out that form. A second thing that happens sometimes is that people change their mind and they forget or they don't tell or they don't think it's important. And so they don't change the documents. And they also then forget to tell their agent that they wanted a change. And so then we're operating from old information with a document that from whoever is viewing it perceives as the current document, but that the individual wishes to have something other than what they have written at some point in the past. There can be some issues sometimes with the healthcare provider filling out or completing those advance directives, especially if the provider is not in agreement with your decision. And I'm mostly thinking about some hospitals will not abide by your aid in dying request if that is how you are looking to have your advance directives. Family members cannot really override your advance directives without your permission simply because it is a legal document. Family members can disagree, and what I have seen happen from time to time is that if family members disagree, then I have seen healthcare professionals err on the side of not doing as much aggressive treatment or not delaying treatment simply because they don't want to be caught in the crosshairs of family disputes. So if one family member says, I disagree that mom should be taken off the ventilator at this point in time, usually what I have seen is that the healthcare professionals will leave the ventilator on rather than trying to deal with the family disputes. So with that as kind of a quick background, let's talk a little bit about the various tools that we have available as part of advanced directives. So what is a DNR? A DNR is basically a do not resuscitate order. It is a legal document, and it basically tells the provider and the world that you do not want CPR or cardiopulmonary resuscitation. For those of you who don't know what that really means, in reality, it means do you want medical professionals, private individuals to basically perform CPR? If I'm doing it as an individual and I'm punching on your heart and I'm breathing into your mouth or whatever methodology that I am using as a private individual, that's one type of CPR. The other is that when EMT comes and they're going to put the flaps on your chest to restart your heart. So that is what CPR is. And what a DNR does is it tells the medical professionals that you do not want your heart and your breathing to be restarted if your heart signs. For it to be legal, it has to be signed by your healthcare provider. So if you sign a DNR order, it's really important that you let people know that you have one. So tell your family and other important people in your life. We really, really recommend that you wear either a bracelet or a pendant with the instructions letting EMT and other people know that you have a DNR order. Also have copies readily available in your home. We suggest, and this has been the training for many, many years, is that if you do a DNR, that you post it on your refrigerator. EMTs have been instructed that that is where you should look for these orders. Having these copies in your safe or your file cabinet are really not in a very good place because they're not helpful. I'm out of it. Am the one who needs CPR, and I don't have the ability to get up and find it, or I'm in a car accident, or I'm in the hospital, or whatever. So having people know about it and having it readily available is how to get the best use of it. Now, sometimes people ask the question, what happens if life support is started? And if it is started, it can be stopped. If family or others can provide the documentation to show that CPR is not wanted by the individuals, then EMT can stop at the scene, whether you're at the scene of an accident, whether you're in your own home, whether you're in a hospital, doesn't really matter where, they can always stop if adequate documentation can be provided. If there is no documentation, then the EMTs will go ahead with CPR and they basically ask questions later. If your heart is stopped and there is brain damage or other damage to your limbs or whatever, your power of attorney can stop other life supports that may be keeping you alive. The other thing to mention is that one of the things I have seen a few times in my life is that if people are having difficulty providing proof or documentation that the individual does not want CPR, sometimes the EMTs are going to ask for additional documentation in the moment. And sometimes people can, in fact, provide that information, and sometimes it's a little more difficult. So the best practices for a DNR is that it has to be completed by both the patient and their doctor or healthcare provider. It does definitely have to be signed by the doctor for it to be valid. That is part of Colorado's law. I don't know what it's like in other states, but I do know in Colorado, that is one of the requirements. As we said earlier, discussing your preferences with your agent, your alternates, your doctor, religious leaders, anybody who might be in a position to have to provide information to EMTs or other healthcare professionals, they should know about it. And then always wear the pendant, which indicates what your preference is, or the necklace. Again, it's optional to do that, but if you're really sincere about it, we definitely ask that you wear those. Additionally, make sure that the people who need to know have copies. Again, copies are extremely important. In Colorado, we now have a law that says that a copy, a Xerox copy or a faxed copy of an original signature is as valid as a signature that you would provide as what we might call a wet signature. So do not worry about, well, that's a faxed copy. That will still be accepted.
Mhm.
Now, part of what happens sometimes is that EMTs are called to the scene of a situation, um, and making sure, again, that people have those instructions is what you want to do, and that the necessary documents are there to stop CPR. Where I find this to be most annoying, if you will, is that sometimes I personally have worked with my clients and we have all of the necessary documentation on file. But then, especially like in home care or in like assisted living or nursing homes, we have all the documentation, we have provided it to the personnel, and then we have temporary personnel in who are filling in and they panic, or we have family members who panic and they call 911, and then ultimately they don't know. And then I have seen CPR administered in those situations. And so that's, again, just trying to make sure that people are aware of what your wishes are, even if they are temporary people in your life. Colorado does have a pre-printed form that's best practice to use. You need basically identifying information like your name, date of birth, gender, hair, eye color, race, ethnicity. You indicate on that form what your instructions are regarding CPR. It does have a box that says that if you do not want CPR, or if you do want CPR, you can check that box as well. And then there is also an option on that form if you want to do tissue donation. Again, a lot of people value the ability to donate their tissues, whether it's organs or whether it's just skin or eyes, retina. There's a lot of things in your body that, even if you're very, very ill, can still be donated. And if anybody is interested, on our website at the YouTube channel, there is a whole section, or there's a whole video on how to do tissue donation and bones, organ donation, etc. Make sure that the healthcare provider has signed it and that it has the medical license number on the form. And then if you are in hospice and sign one of these, then also make sure that we know who the hospice is that you are receiving services from. To get a copy of the form, you can go through our website and you can click on this link should you, when I send you the forms or the PowerPoint to do that. Now let's switch to feeding tubes. Feeding tubes basically are another way or method, if you will, that we can prolong life. But a lot of people have very deep-seated feelings about what feeding tubes are, what they can and can't do, and why they may or may not be important to you. Some people are very much, I am not going to ever want one of those. Other people say, well, I may want one for a while. And then other people will want to have one as long as they are alive. So this hopefully will give you a little bit of an understanding of what tube feeding is and how it works. So basically, the purpose of it is to supply nutrients and fluids to your body if you are having difficulty chewing or swallowing. It takes that nutrition through some type of a tube that either goes through your nose, your stomach, or your small intestine. And then it puts the nutrients, if you will, directly into into your stomach or into your small intestine. The feeding tubes are soft. They're a plastic flexible tube. The liquid nutrition goes through your body to your GI tract, and then healthcare providers can also administer medicine through the feeding tube. It's a way, if you will, to get food into your stomach or into your intestines. And if it goes into your stomach, it's absorbed and stored there and digested. If it goes into your small intestine, then basically the goal is for the nutrients to be absorbed into your body and for you to be able to continue with your daily routine. There are several different types of feeding tubes. So one is the nasal, and it goes through your nose. I personally find those just very repulsive, just because I find that hard to look at. The G tube goes directly into your stomach. A J tube goes directly into your small intestine, or you might have a GJ tube, and that drains the stomach fluids, and then it allows medicine and other food to go into your small intestine. So again, the type of feeding tube is dependent, if you will, on what your situation is. So feeding tubes help to support your metabolism and your digestive health. Uh, we do feeding tubes sometimes when we have severe eating disorders. Um, Sometimes you have head and neck cancers or other injuries. Sometimes your GI system is compromised and your muscles and your nerves cannot digest your food. Sometimes you have other conditions that just interfere with nutrient absorption, or you may have had surgery or medical illness and you can't swallow. So again, there are a lot of different reasons why your healthcare professional might suggest that you use a feeding tube. Your experience in terms of this feeding tube is really going to be dependent on why you need it and how it is administered. If you are in the hospital, basically the hospital personnel are going to take responsibility for cleaning it, for managing it, and all of those kinds of things. If you go home, either you or your caregivers are going to need some type of training. And you may need special equipment to set it up, to flush it, and to keep the site from getting infection. So as I said, there's several different ways that a feeding tube can be inserted. It can be inserted through the nose. This is where they gently insert the tube through your nose, go down your throat and your esophagus, and then they put it in through down into the stomach. They do a lubricant kind of process and ask you to sip water as they're doing this procedure. There is some risk to this. We have a neighbor who required one of these, and his esophagus was punctured. And while he can still talk, somehow it interfered with his vocal cords, and so he can only talk at a whisper. So sometimes there are side effects to this. Endoscopically, there they put a long camera into your stomach, basically, and then they thread, if you will, this tube using the camera into your abdomen, and then they insert the feeding tube through the abdomen. And sometimes you hear of that as called a PEG or a PEG-J, but basically they do an incision and they put it straight into your stomach. If they do it radiologically, They use x-rays. Again, they make an incision into your stomach, and then they use x-rays to go through and insert it that way. And the last way is surgically. So basically, they make a larger cut into your abdomen and they insert it basically then through what's called a laparoscopy. And they use, again, cameras and other instruments to make sure that it is positioned correctly. So you can eat. There are two things that happen while you're eating with a feeding tube. One is you might just eat 3 times a day or whatever, like you would normally do, and it's a liquid nutrition that is poured into that feeding tube. Usually that's how it's done. If you are having feeding tube into your stomach, if you are not able to ingest that much food, then they may do it continuously, where you may get small amounts of food daily into your smallest intestine on a regular basis. And again, the healthcare provider, whoever it is, they will determine what works best for you, what you can tolerate, and then the amount of fluid and vitamins and minerals and calories that you require to make this work specifically for you. You do have to care for the insertion site, and you have to clean the skin. You have to make sure that there are no clogs in the tube. Again, this is to prevent infections. You wash with soap and water at least once a day, but more if you have some kind of drainage. They usually put some type of gauze and other creams around it to protect the skin. You have to clean between cleanings. Again, you want to keep the bacteria out. Bacteria loves to grow where there's warm and moist spaces. If it's inserted in through the nose, then you have to keep that nasal passage clean. And again, if there's any kind of warmth or signs of infection or redness or pain or swelling or anything, you will want to notify your healthcare provider. So you have to flush it regularly. You have to have it changed regularly. And if it comes out of place, you need to immediately go to the emergency room to have it back inserted. Some of the side effects, which we've just talked about a little bit, are that you could have sores at the site of the insertion. The tube could get clogged, damaged, or displaced. You could get infection, and I have seen over the years a lot of people have very successful stomach tubes, but I've also seen a number of people over the years who have suffered from a lot of infection. And when I have seen that, that has sometimes been the trigger, if you will, for the person to say, I don't want this anymore. And so please remove it, knowing full well that they have now begun the journey of not being able to accept any type of nutrients in their body outside of possibly an IV, and that death probably will come shortly. You often, with feeding tubes, experience things like constipation, nausea, or diarrhea. Again, this happens because oftentimes you're not moving around as much, or you're not getting the formulas quite balanced to meet your needs, and so that happens. The worst thing that can happen with feeding tubes is aspiration pneumonia. And this is basically when the food does not go into your stomach or into your small intestines, but it gets stopped at the lungs, and then your lungs fill up with food, and then they cannot breathe. And that's pretty painful and difficult for people. people can be on feeding tubes, sometimes just for several weeks, sometimes for several months, or sometimes for years. And I have seen all of those over the years in my life. Okay, so that kind of concludes the conversation about feeding tubes. Let's move for a few minutes to ventilators. So a ventilator basically acts as a bellow or a thing that moves your lungs in and out so that they can take in air. The respiratory therapist is the healthcare professional who is primarily responsible for ventilators, and they then will test and work and see how much air to push in and out of your lungs. Very similar to oxygen, but ventilators deliver oxygen right straight into the lungs and are much more effective. Sometimes when people are on a ventilator, they'll also have a mask, which helps to bring the air and keep it located around your nasal your nose, so that it can stay and you can get the best benefit. Ventilators are sometimes also called mechanical ventilators. It's basically a machine that helps you breathe when you're sick, injured, or sedated for an operation. And it pumps oxygen right straight into your lungs. And it also helps you get the carbon dioxide, which is the harmful waste gas in your body, and it basically gets rid of that as well. So if you are on a ventilator, if you're conscious, you can hear. Many people, though, are very, very sleepy. Another side effect of ventilators is not that it necessarily is the result of the ventilator, but again, because we're artificially pushing air into your lungs, you might see other organ failure, such as your kidneys may not be working correctly, or your heart may not be pumping as fast, or your liver may shut down. So while ventilators have their purpose, and they do very, very well, there can be some side effects, especially if your health is somewhat compromised. Once you get off of a ventilator, you may just be put straight on 100% oxygen at some level, again, depending on how much air you can breathe into your lungs and how much support you need. You may also be given a tracheostomy, and that sometimes is done as an intermediate step. So they take you off a ventilator, put you on a tracheostomy, which is basically a hole in your trach, and then that helps you to breathe through that process until you're totally weaned off of the ventilator, and then you can go on oxygen. How long can you be on a ventilator? There's not really any rules, but mortality is about 35%. So if you are put on a ventilator, about 35% of people do pass away. So that's a pretty high number. About a half of survivors are taken off a ventilator within 90 days. If you're on more than 90 days, your survival rate is pretty low. Life expectancy, if you do survive for 1 year, is about 24%. 5-year survival after being off of a ventilator is about 14.6%. So those are not small percentages. And if it's something that is important to you, I would certainly consider it. Getting off of the ventilator or weaning basically just means that they want you to start breathing on your own. Ventilators are usually only used in hospitals or ambulances. They're not usually used in home care because of the high level of care that one needs. So again, if you're in the hospital, they're usually going to wean you off of that before you go home, or you go to an acute rehab or to long-term care. Uh, so this was another statistic that I found in terms of chances of survival on a ventilator. So the survival rate in this study is about 82% after the 5th day and 75% after the 10th day. So while I hear very frequently people say to me, I'm not necessarily wanting to be put on life support, um, the survival rates are pretty good if it's a short-term situation. So again, all decisions have to be made on an individual basis, but just because you're put on a ventilator um, doesn't mean that you're at your end of life, number one. And number two, depending on why you're on a ventilator, it may have benefits. So just for as a closure then, that kind of brings us to a close for this afternoon. So before we close, I just want to mention briefly a little bit about some of the society's programs. So we do have a dental program where we can provide dental grants to low-income individuals who do not have insurance and or who do not have Medicaid. And we can serve Metro Denver as well as the Western Slope. We have a telephone buddy program that primarily focuses on the city and county of Denver, but we have about a third of our people are outside of the city and county of Denver. This is where a volunteer calls once or twice a week to check in on people. We do have a mental health counseling program that is focused specifically only on residents of the city and county of Denver. And you can get counseling from licensed clinicians for non-Medicare, non-Medicaid reimbursed mental health diagnoses. So it's more situational kinds of things. It's anxiety, it's grief because I lost my husband. I had to move to an assisted living. So it's for that kind of thing. We also have advanced care planning, which this is a part of. We do some educational programs. There's a toolkit on our website, and there's quite an expansive set of videos on our YouTube channel as well. We do general counseling around public benefits, Medicare, Medicaid. We have a housing and home care locator if you're looking to move on our website as well. And then we have a big holiday pet basket project, which is available primarily in the Metro Denver area. Our Salute to Seniors for 2025 will be August the 23rd at the Greek Event Center again on Alameda and about Colorado Boulevard. In person, it will be virtual the next day, August the 24th. We do a Medicare Monday series where we provide educational programs as well as counseling and other support for people on Medicare. The Medicare Monday programs run from October 1st, usually October 15th through early December when open enrollment closes, but then you can just get Medicare counseling or Medicare support throughout the year. You can visit our website or our YouTube channel. We also have a consumer newsletter, which is a print copy, and if you would like copies of it, you can certainly register at the website and we'll get you on that list. Do a series of consumer and professional training, as well as public policy and advocacy. And we distribute a guidebook with housing and home care resources, as well as pre-printed forms for advanced care planning. And the front section deals with healthcare insurance. So with that, I thank you for joining us today. And with that, I will stop and take a few questions if there are any. So somebody put something in the chat, so let's start there. So somebody suggests that while working in intensive care, they observed many patients were placed on ventilators due to COVID, both young and old, and often people were not able to be weaned. I think COVID brought a really difficult, if you will, type of virus to our bodies. And I know that many people had a lot of difficulty. So yes, that was very sad. Somebody else said, as you shared about DNR and documentation, can you please clarify what forms are needed within a medical facility as opposed to what's available in the community? What's the difference between DNR, CPR, and the MOST form? And what tools do you recommend for a DNR and help guide? Okay, so let's go through those kind of one at a time. So in a medical facility, either fortunately or unfortunately, I don't know which, hospitals require a do not resuscitate order, and you can say, yes, I want CPR, or you can say, I do not. So hospitals will ask you that question. Hospitals also require a medical power of attorney. Especially for Medicare beneficiaries. They don't necessarily require it for everybody else, but Medicare beneficiaries. And again, as I said earlier, that's a Medicare law. The second part of this question then is whether or not what happens in assisted living and nursing homes. So assisted living and nursing homes, the first thing that they are most of the time going to ask you for is what they call the MOST form. A MOST form basically is a medical order for scope of treatment. It was adopted by the state legislature some years ago. And excuse me, but my computer is telling me that it's low on batteries, so I'm gonna plug it in here so I don't lose you all. I guess I lost everybody. Okay, so sorry for that disruption. So assisted living and nursing homes tend to ask for the MOST form. And the MOST form is a little bit different in that it asks specifically 3 different types of information. It asks whether you want any type of antibiotics. It asks whether or not you want CPR, and it asks information around kind of end of life support. So the MOST form is used pretty much 100% by nursing homes and assisted livings because they're pretty much required by the state health department to have a copy of that on file. If you want life-saving measures, you simply indicate that on that. If you want certain types of life-saving measures and not others, you can indicate that as well. When people go to the hospital or sent to the emergency room from a nursing home or an assisted. Usually that most form is one of the things that accompanies them to the hospital for the specific purpose of telling the emergency room personnel what type of care that the individual has selected. If you, so in addition to the most form, in terms of just advanced directives at an assisted living or a nursing home, you should also specifically have your medical power of attorney. Because then your medical power of attorney can make decisions for you. If you are in the community, you can still have a most form, but it's not required. But I would advise that you have a medical power of attorney. In terms of a DNR, which is basically a CPR directive, the DNR, do not resuscitate, is the CPR directive that says do not do or administer CPR. So your medical power of attorney can indicate that you want CPR or you don't, or you can have the DNR order, and that can give those instructions as well if you are in the community. And you can or cannot have then the most form depending on what you want. The DNR only covers CPR. The most form covers what type of treatment you want in the way of antibiotics. It covers the CPR directives, and it covers whether or not you want like food and water at end of life. The other thing that sometimes gets confusing in here is the living will. The living will specifically is there for the specific purpose of if you are unable to make decisions, you are unconscious, two doctors agree that you will not be able to survive, then they can remove all life support, which usually means a ventilator, feeding tubes, IV tubes. So basically it's removing all of those types of life supports is what a living will does. But it's only in effect if you are unconscious and you've got a terminal illness and two docs agree that you are not going to ever be able to regain consciousness. I personally suggest to people that the living will sometimes just confuses things because your medical power of attorney can initiate everything that a living will can do. And you can have discussions as you go along. But some people choose to have both a DNR, a living will, as well as a medical power of attorney, as well as a most form. And if you have all of those, just make sure they all say the same thing and they're not conflicting. Now, that was a very long answer. Do forms expire or need to be renewed? Forms technically do not expire. They should be always valid regardless. It's like a notary. They don't die when your doctor dies or your medical provider retires or whatever. Any other questions? Okay. Well, thank you all for your patience, and I will send out the slides later this afternoon. So if you wish to review them again, you have access to them. Thank you all for attending, and I look forward to seeing you soon. Bye.